And we have Dr. Dodul Mondal, who is a radiation oncologist, senior radiation oncologist in Apollo Hospital in Indraprastha, Bolo. We have Dr. Vimal Pandita, who is a senior medical oncologist in Arihant Hospital, Dehradun. We have Dr. Jitendra, who is a senior medical oncologist in Shalby Hospital, Jaipur. And we have Dr. Chhavi Arora with us, who is a senior radiation oncologist in BL Kapoor Hospitals. So I welcome you all. We have Dr. Bhuvan also, who is a very special and very dear colleague of us in Max. He will be moderating the panel. He's a senior medical oncologist in Max Hospital, Gurgaon. So welcome you all. Lecture delivered by Dr. Amish Vora, followed by a panel discussion moderated by Dr. Bhuvan. So I welcome Dr. Amish to start his lecture.
Thank you, Dr. Shefali. I am honored that I'm part of such a great exercise which you have started. Are my slides visible? So my topic today, as Dr. Shefali had given me, is unresectable stroke metastatic carcinoma esophagus. Today's topic, I'll try to cover the natural history of metastatic CA esophagus, palliative treatment, systemic chemotherapy, targeted therapy, immunotherapy, and if time permits, NGS or molecular diagnosis based treatment, which I doubt, but I will try to do that. On a happier note, all surgical oncology colleagues and all radiation oncology colleagues, they always say that, chemotherapy in a stage 4 cancer normally kitna jiyega, that also especially stage 4 esophageal cancer. So this particular video I have taken from Dana-Farber website. This gentleman was diagnosed as a metastatic CA esophagus in 2013. And this picture was taken in 2019. And on his shirt, on the left-hand side, if you see 100 is written. So this picture was taken when he was coming for 100th chemotherapy. 100th chemotherapy century. So every 3 weeks of chemotherapy, he used to drive down 200 kilometers from his house, and 6 years or 5.5 years down the line, his performance status, if you see the video, is 0 or 1. In fact, he was looking more energetic than the partner who was accompanying him for chemotherapy. So, these things do happen. This is reality. It is not that these things don't happen. And these things also encourage us. So this is the 100th chemotherapy. Not everyone is so lucky. We all know that stage 4 esophageal cancer is a dreadful disease with very dismal survival, very, very painful death. And the quality of life is very miserable, as we all know. That you are not able to eat, you are not able to speak, and weight loss because of that. So today's topic also covers palliative treatment, which includes stent placement, pain management, nutrition, radiotherapy to the painful sites, or radiotherapy to the sites where it is required as per the discussion with tumor board, or laser or chemotherapy. So this is something which we are not going to discuss today in detail, but please remember everyone that no treatment of unresectable or stage 4 esophageal cancer is complete without all these aspects. And these are extremely important aspects. You may increase survival by say 3 months, 4 months, 5 months. But if the patient is not able to eat or not able to enjoy any quality of life, what's the point? Next slide, please. Okay, so this is the landscape of systemic treatment in 2021 looks like. If all of you see, you will say that this is maddening. How are we going to look at all these aspects? The two black boxes are on the extreme corner. One is adenocarcinoma, one is squamous cell carcinoma of esophagus. And in between, there are many other boxes. So as you will see, there are a lot of options. How do we treat? And how do we arrive at these options? One by one, in next 15 minutes, I will go through it. Anyone and everyone who is a medical oncologist or a surgical or a radiation oncologist, this is going to be our future. No matter whether we like it or not, no matter whether we say कि यार कौन ये molecular के headache में पड़ेगा, your practice is going to be incomplete if you do not understand the molecular aspect of cancer. And heterogeneity of gastroesophageal cancer is clearly evident in this slide. As you can see, the number of mutations which have been identified right from upper esophagus till gastroesophageal junction. Just to small summarize, please remember the squamous cell carcinoma of the esophagus, as well as the upper and the mid esophagus, they exactly behave like head and neck cancer. So if anybody who has understood head and neck cancer heterogeneity of molecular mutations, esophagus squamous cell exactly behaves like that. While the GE junction behaves like stomach, and as a result, GE junction and stomach adenocarcinomas are clubbed together in the treatment, while the squamous cell carcinoma is a different entity and it is treated in a slightly different manner. Can I have the next slide, please? Okay, this we have covered as Dr. Shefali has said, so I will not go into the details of this, but please remember cross trial was the first trial. Even in fact today, I had 2 T3N1 esophageal cancer. Both of them, it was difficult time for me to convince them that why do they need CTRT when their disease is operable. I had to share screen. I did a Zoom meeting with both the families. I shared screen and I tried to explain to them the lower graph. And if you see the lower graph, where extremely upper line and the lower line survival curve are squamous cell carcinoma of esophagus, T3 N0 to N2 and T2 N1 N2 disease with chemotherapy, radiotherapy followed by surgery. You see the survival as compared to the most bottom where it is operable. So no longer operable esophageal cancer also will remain operable. Next slide, please. Without neoadjuvant chemoradiotherapy. And unless and until you give neoadjuvant chemoradiotherapy, these patients will not be eligible for study like Checkmate 577. Next slide, please. And you will not be able to give them immunotherapy as a maintenance like we have looked at durvalumab study in lung cancer. We have now nivolumab study in esophageal cancer, that if there is a residual disease during the time of surgery, please offer immunotherapy. This is cross trial and Checkmate 577 are the 2 landmark trials which have changed our practice today. Next slide, please. So coming back to systemic treatment in metastatic or esophageal cancer, this is the NCCN guidelines I have taken out today. So this is the latest guidelines. There are multiple options of this, and this is the first line. Next slide, please. So we will see how systematically, this is the second line. We will see that also. Next slide, please. So let's assume a 59-year-old male who has CA esophagus and the biopsy report has come as CA esophagus, either poorly differentiated adeno or squamous cell carcinoma. This was the scene 8 to 10 years back. Next slide, please. What are the options we had during this time? So if you see, the first topmost is the best supportive care. You do not treat patient. Patient will be alive or patient will survive for 2 to 3 months. Then came single agent chemotherapy and then came the combination chemotherapy. The green bars are doublets and the yellow bars are triplets. If you see, there is not much of a difference between a doublet and a triplet, especially if you see FOLFOX, the last bar. The median survival is around 11 months with that. 1 year overall survival is 40%. And few lucky ones survive up to 2 years with combination chemotherapy. So doublet is as good as triplet. Next slide, please. So only chemotherapy in a metastatic CA esophagus, the standard rule is median survival is less than 1 year. Few lucky ones go beyond 2 years, and 5 years are the only one who hardly 1 to 2% survive beyond 5 years. Combination is better than single agent. Doublet is better than triplet in terms of tolerability and in terms of efficacy. FOLFOX is the most widely used regimen in the first line, and 5-FU and oxaliplatin or 5-FU and cisplatin have been compared in every other new trial as we will go forward. In a young fit patient, triplet in a phase 2 trial had shown median OS of 17 months. But apart from that, there is no difference. NCCN guidelines, ESMO guidelines, and ESCO guidelines, they mention that when you are selecting chemotherapy in a fit patient, doublet serves your purpose. Triplet just adds on to the side effect profile of it. One of the newer aspect in 2020, which was presented in ESMO, that if a frail elderly patient above 65 years of age, if you give 60% dose of Folfox as compared to standard dose, the efficacy remains exactly the same, and tolerability, 90% of the patients could complete the planned treatment. So in an old frail patient, reduced dose of Folfox. In a young fit patient, full dose of Folfox. If you are selecting a combination chemotherapy regimen for a metastatic CA esophagus in the first line, this constitutes the standard of care in 2021. Next slide, please. So this is what the NCCN normal guideline says. And if you see the fourth bullet point says that the doublet is better than triplet. And remember, the dosages which are written in the trials, except for category 1, you can modify the dose based on performance status, comorbidities, and toxicity profile. This is well within the realm of a treating oncologist. If it is category 2A, you need not stick to the exact dose which is published in the clinical trial. Please remember that. I didn't know this till some time back when I was trying to modify the dose. Next slide, please. So beyond chemotherapy, because we know the median overall survival of less than a year is not acceptable. Let's look at the next thing. HER2 new. We all know that not a single breast cancer patient biopsy is complete without HER2. In esophageal and in gastric cancer or in gastroesophageal cancer, 15% is the incidence of HER2 positivity in these patients. Next slide, please. So this was the famous TOGA trial, which when it came, we all were very excited. In 2009, it was first presented, 2010 follow-up data, and 2011, the approval came. TOGA trial, what it did was inoperable or a metastatic squamous cell carcinoma, which are HER2 positive by immunohistochemistry. And as we can see, what was the caveat there? Was randomized between 5-FU or capecitabine plus cisplatin versus addition of trastuzumab to the same chemotherapy. Next slide, please. This was the overall survival. The first time the overall survival went beyond 1 year, that is 13.8 versus 11.1 month. Now, surgical oncologists would say, 2 महीना का extra survival के लिए इतना महंगा drug. Next slide, please. So this is what it said. If you see the last 3 purple slides, for purple bar, which suggests that whenever trastuzumab is added, the overall survival has gone beyond 12 months, in fact, up to 18 months. What happened in TOGA studies, they took IHC 1+, 2+, and 3+ all in the study. So the third last bar was all comers of IHC positive, 0 to 3+. And the survival was 13.8, that was the all comers. If you divide this into IHC 3+ or IHC 2+, which was FISH positive, your median survival goes up to 16 months. And if you subset analysis of IHC 3+, which were FISH positive or FISH amplified also, your median survival goes up to 18 months or more than 1.5 years. So chemotherapy alone, the median survival was 11 months maximum. When HER2 expression, and if HER2 is strongly expressed, your median overall survival can go up to 1.5 years. This was a jump of almost 50% in the horizon. Next slide, please. Unfortunately, what happened during that time, because of success of TOGA trial, everybody jumped onto the bandwagon of this. There was a Lepatinib, then there was TDM1 also was tried in these studies. Unfortunately, none of these studies succeeded the way TOGA study succeeded. As a result, next slide, please. NCCN said that if there is HER2 overexpression positive adenocarcinoma, please remember HER2 positivity is seen in adenocarcinoma, in squamous cell esophageal cancer. If HER2 is positive, please recheck your biopsy slide. You should add trastuzumab with cisplatin and 5-FU. Now you can replace cisplatin with oxaliplatin, absolutely allowed in clinical practice. The only thing that category 1 becomes category 2A, but it doesn't matter. In a day-to-day life, we use Folfox, much more common than 5-FU plus cisplatin. And if you add trastuzumab to that, then the median overall survival increases. So that is the standard of care. Next slide, please. What happens when patient progresses on trastuzumab? And please remember, the TOGA trial did not have any patients where on second line they received trastuzumab deruxtecan. This is an antibody conjugate. I will not go into the details of trastuzumab deruxtecan, but this is a second or a third generation anti-HER2 treatment. All the trials with trastuzumab deruxtecan are named as Destiny. Like, for example, pembrolizumab, all the trials are named as Keynote. Nivolumab, all trials are named as Checkmate. Similarly, trastuzumab deruxtecan, all trials are named as Destiny. So what did Destiny gastric O1 trial? What it did was, all patients HER2 positive gastric or esophageal cancer, at least prior to previous regimens, those who had used, they gave trastuzumab deruxtecan and randomized to physician's choice of treatment. And this included either irinotecan or paclitaxel. Next slide, please. Clear cut. So this was a positive study. Clear cut difference, or that separation of graph in survival, that is 12.5 versus 8.4 months is the median OS. And PFS, if you see, there were many long-term responders. Next slide, please. As you can see that. Next slide, please. Yes. So this is 1 year PFS with trastuzumab deruxtecan was 30% compared to 0% with either irinotecan or paclitaxel. That means all the patients in the second line, HER2 expressing adenocarcinoma of esophagus, progressed within a year if they were given second line chemotherapy, either irinotecan or paclitaxel, versus 30% who continued to respond with trastuzumab deruxtecan. And 1 year overall survival was nearly double, from 29% to 52%. Next slide, please. This is as a result.
Dr. Jitendra, I think please mute yourself.
He unmuted. He muted himself. Yeah. January 2021, trastuzumab deruxtecan is approved by FDA in patients with previously treated with trastuzumab and with one more line of chemotherapy in HER2 positive advanced gastric and gastroesophageal cancer. Next slide, please. So to summarize so far, what we have done is all adenocarcinoma esophagus should have HER2 status checked. If IHC 3 plus or IHC 2 plus with FISH positive, trastuzumab should be added. After progression, trastuzumab deruxtecan can be considered, and the overall survival in the first line increases from 10 to 19 months. And in the second line, 1 more year can be added if trastuzumab deruxtecan can be used. Next slide, please. Patients who are HER2 negative. So assuming the first line chemo you have given as Folfox, patient relapses after 9 months and HER2 negative, what next? Next slide, please. So here, People tried Ramuciroma. We all know the mechanism of action of Ramuciroma. This is again an anti-VEGF drug. This was combined with paclitaxel in the second line treatment in HER2 negative patients as compared with paclitaxel plus placebo. Next slide, please. And what they found was the median overall survival, survival was 9.6 months compared to 7.4 months. And as you know that majority of the companies, they love statistics. So they said 30% increase in median overall survival. Next slide, please. There is a lot of, so this is we all know the subset analysis. Almost all the subgroups benefited with addition of Ramucirumab. Next slide, please. One of the critics when I was discussing this thing in one of the webinar organized by All India Institute, Dr. Atul Sharma sir, who has been our sir for many of us, irinotecan, when used as a second line, gives almost similar overall survival. But please remember, Rainbow was a phase 3 randomized trial. Next slide, please. So far, so what is if HER2 is negative? We saw if HER2 is positive. If HER2 is negative, the first line chemotherapy, most probably FOLFOX. The second line, because you have not used taxane in the first line, you add taxane with ramucirumab if patient can afford, or you give irinotecan in the second line, or you can give FOLFIRI also in the second line, like what we do in colorectal cancer. Next slide, please. We are still not happy. Dil maage more, and no topic today can be complete without immunotherapy discussion. And my slides are little, we all know for the students, PD1 is on the T cell, PD-L1 is on the cancer cell. PD1 and PD-L1, they attach to each other, and as a result, what happens is that the immune surveillance is escaped by tumor cells. Next slide, please. What chemotherapy does is chemotherapy either attaches to PD1 or PD-L1. As a result, PD1, PD-L1 combination is not there, and T cell recognizes this is the bad tumor cell and I'm going to kill this cell. So immunosurveillance evasion is reversed. This is in a nutshell. There are many other mechanisms of action. Next slide, please. Landmark study. Nobody, no student of oncology can ever forget this study. This was the first keynote where the tissue agnostic approval of a drug was done. Tissue agnostic means anywhere in the body the tissue of the cancer is originating, but if the patient has this particular genetic event called MSI high or deficient mismatch repair gene, then this particular study comes into the picture, this drug comes into the picture. 2 to 3% of esophageal cancer would be positive for MSI, but please, please, please do not miss this particular genetic event. The study can be done with simple immunohistochemistry. Of course, PCR and NGS can also detect either MSI or DMMR, but immunohistochemistry, which is costing 6,000 to 8,000 rupees. So no single patient of metastatic esophageal cancer, MSI should be missed. Next slide, please. So what happened in this landmark study, 86 patients of different tumor subtypes. In the pie chart on the top, the yellow represents gastroesophageal cancer. And this pembrolizumab was given up to 2 years. You can see the top chart where at the end of 2 years, the first few histograms, the pembrolizumab stopped. They stopped giving. Still, patient continued to respond. And you can see in overall survival in my right and bottom corner, there is a plateau of progression. People stop progressing after some time on pembrolizumab. Next slide, please. So is this by chance? So what did pembrolizumab company did is that in the third line, in the second line, in the first line of esophageal cancer, they had these studies. Next slide, please. They combined all 3 studies and they took out MSI high in all these studies. On my left-hand side, the standard intention to treat graph is there. On my right hand side, MSI high is there. How can the two survival graph be so different? In Solo 1, recently in olaparib in ovarian cancer, I saw this much of separation of curve. Otherwise, I have not seen so much of separation of curve. Next slide, please. As a result, NCCN guideline says that second line pembrolizumab for all MSI high or dMMR tumors in esophageal cancer, you should offer single agent pembrolizumab. Although all across the world, people have started using in first line also. Like in colorectal cancer, this MSI high is now first line approval by all government agencies. This very soon will come. Next slide, please. Coming to other than MSI or dMMR tumors, next slide, please. Quickly, I'll go to the third line, second line, and the first line, and then I will try to wind up. Third line, nivolumab study is called as Attraction 2. Pembrolizumab is called as Keynote 04059, and Javelin was 300. The green boxes represent positive study, and the red box represents negative study. I will come to that why it is negative. The Attraction 2 and Keynote 059 were single arm studies. Nivolumab was compared to placebo. Pembrolizumab was not, it was a single arm. Only difference in the two curve you see PD-L1 positive and negative. While Javelin was compared with chemotherapy, Avelumab was compared with chemotherapy. As a result, authors feel that Avelumab study was negative, but if you give Avelumab alone, then that also can be positive. Unfortunately, in oncology, we go by positive studies, and as a result, next slide, please. Nivolumab and pembrolizumab both have been approved for third-line esophageal cancer or chemorefractory esophageal cancer. Chemorefractory in oncology we define as failure of 2 lines of treatment, so it becomes a third line. So a third line adenocar's third line nivolumab and third line pembrolizumab both are approved in esophageal cancer. Pembrolizumab is approved if CPS is more than or equal to 1, while nivolumab is approved irrespective of PD-L1. Next slide, please. Second line, again, these are the two studies which are there. In fact, Keynote 061 and Keynote 181 both were negative studies. So a subset analysis was done here. And subset analysis in Keynote 061 suggested that if you have a CPS score of PD-L1 more than 10, then you have this much separation of the curve. Next slide, please. Squamous cell carcinoma only and nivolumab. Attraction 3 study. This was a multi-center randomized open label phase 3 trial where nivolumab versus chemotherapy, nivolumab alone versus second line chemotherapy was given. Next slide, please. And they found the 3-year follow-up data was presented in ASCO 2020. They found that 15% of patients treated with nivolumab alone are still alive at 3 years as compared to 7.4% in chemotherapy alone arm. Next slide, please. As a result of these two data, the second line all comers, nivolumab is approved in all squamous cell carcinoma, while pembrolizumab is approved only when there is CPS more than 10. Please remember, pembrolizumab in the third line is approved when CPS is more than 1, while nivolumab does not require that. In second line, nivolumab is approved in all comers, while pembrolizumab only if CPS is more than 10. Next slide, please. First line therapy. First line therapy approvals are last year and this year coming up. We need more follow-up data and there will be more separation in the survival curves. But till that time, whatever data we have available is a CheckMate 649, where nivolumab plus chemotherapy versus chemotherapy alone was planned. Again, a subset analysis was done where CPS more than 5 was seen to have a superior overall survival compared to chemotherapy alone. Next slide, please. Similarly, pembrolizumab is approved in the first line based on Keynote 180 and Keynote 181. The combined analysis again showed that if you have CPS more than 10, patients do better compared to you have all-comer patients. But this is again a shorter follow-up. We do not have 3 years, 4 years, and 5-year separation of the curves, so we would wait for that. But till that time, because chemotherapy alone has a dismal, next slide, please. The first line approval of nivolumab is only in adenocarcinoma. Again, I don't believe this data too much because this was a subset analysis. This was not a planned analysis. In adenocarcinoma, CPS more than 5, you can add nivolumab to your first line chemotherapy. If you have PD-L1 CPS score more than 10, you can add pembrolizumab either with cisplatin or with oxaliplatin, and both become category 1 as of today. Next slide, please. So this is my last slide. Again, this was the second or third slide I started with. On my right-hand side of my slide, there is a squamous cell carcinoma of esophagus. One block above is MSI high, another is HER2, third is CPS more than 5, and fourth is PD-L1 negative. I would like to start with MSI high. All the students of oncology who are listening today, please, please, please do not miss out a single patient of MSI high, because it's a completely separate genetic event in the history of cancer. If you treat with single agent pembrolizumab, not only you will have a phenomenal success, I'm not saying 100%, you'll have a phenomenal success. You may have some patients who cross 4 years and 5 years also with single agent pembrolizumab. If patients progress on pembrolizumab, then you go on to chemotherapy in this MSI high group. Now let's come to HER2 positive patients. HER2 positive patients, you add trastuzumab to chemotherapy in the first line. You add trastuzumab, you give trastuzumab deruxtecan if the patient fails of that. Only then you think of other options. You come to the first box, that is PD-L1 negative. Your MSI is not high and your CPS score is less than 10. You have single agent chemo, you have doublet chemotherapy, that is FOLFOX. You have a second line of ramucirumab. You have a third line of irinotecan, or vice versa. And again, the patients live longer. And the last box is squamous cell carcinoma of the esophagus, where you can give the first line chemotherapy with or without pembrolizumab or nivolumab. The second line nivolumab alone in all comers is approved in all squamous cell carcinoma of esophagus. That means the pembrolizumab, which was in MSI high single agent, similar nivolumab in a squamous cell carcinoma of esophagus, second line, all comers, PD-L1 irrespective of positive. This can be little confusing. It is confusing to us also, and that's why we keep revising. I don't think I have time to go into the details of CPS scoring because it will take another 10 minutes. I would like to stop here, Dr. Shefali, and I'm sorry for all the glitches happened. And Bhuvan, thank you so much for sharing my slides.
No worries, sir. So very interestingly and very precisely, you mentioned all of the trials in detail with so much of clarity. I also honestly did not know about few things which you mentioned right now, like the dosing adjustment and all. It is recommended by NCCN, honestly. So this was a new opening to me also. So thank you so much. Few questions, sir. So first, Dr. Nikhil has put in, okay, what is the incidence of MSI high probability in metastatic CA esophagus?
2 to 3%, Dr. Nikhil.
Right. And a few more.
But remember, I always share this analogy. When EGFR came in NSCLC, we said, yaar, 18-20% mein hai. When ALK came in NSCLC, we said 3 to 4% mein hai. I have not touched NTRK, but NTRK is another tissue agnostic and it is 1 to 2% in all. So if you take HER2 positivity of 15%, MSI of 3%, that is 18%, and CPS of more than 10 is around 30%. So almost half of esophageal cancer patients in a metastatic setting can be helped beyond chemotherapy.
Right, absolutely right. So this was actually the next question. So if you have a HER2 positive patient along with CPS more than 10 or say MSI high, so how will you choose your targeted along with chemo, or how will you choose your approach to such patient? What will be preferred over other?
Right. So Dr. Shefali, I'll answer this in two parts. MSI high is MSI high. Please remember,
Correct.
and we all know that I believe this is a separate genetic event in the history of cancer, irrespective of the
Right.
tissue of cancer. It doesn't matter.
Correct.
So MSI high should be preferably be given first line pembrolizumab,
Right.
if patient can afford. Once the patient progresses, then we can go up to HER2 progressing or HER2 expressing tumors, right? If PD-L1 is positive and if HER2 expressing, please remember the first line approval of immunotherapy in esophageal cancer. I'm still not very convinced about those data. First of all, there is a lot of subset analysis, CPS of more than 5, CPS of more than 10. Instead of that, like nivolumab as a second line is a much more robust data of attraction 3. So I would say is that the first trastuzumab definitely should be given. If patient has responded very well to trastuzumab regimen, and if patient can afford, then you should look at Enhertu or trastuzumab deruxtecan and then go for immunotherapy. That is how I would do in my clinic, although I'm not aware of, and that is what the last slide which I have taken from UCLA, they also treat the patient accordingly.
Right. And third question would be, so which molecular markers and in which order would you order? So for a metastatic patient, like in the first line, you order MSI, HER2, PD-L1, or where do you, if I put it another way, where do you utilize the NGS in this setting?
Dr. Shefali, can we take this in panel discussion?
Sure. Okay. If this is your, okay, I'll take it back and we'll discuss it later. So any other questions, Dr. Nikhil, in the chat box, or we move forward?
No. There are no
All
questions.
Right. Okay.
I just wanted to tell Dr. Vora that it was an excellent presentation. And as surgeons, we want to keep our life simple. We have only algorithm, operate and send to medical oncologist. I think with that, Dr. Shefali, you have introduced everyone, right?
Yeah. So you please welcome everyone again, and then we start with.
Yeah, so I would welcome all the panelists on board, and we have a very enlightened panel, and Dr. Bhuvan will now take this discussion forward. Dr. Bhuvan, please.
Thank you, Dr. Nikhil. So I would try to make your life a little case which would require your inputs also. So I think I don't see any other, I probably don't know any other GI surgeon on board. So if there are any, I would like.
Sanjeev is there.
Sanjeev is there?
Yeah.
So I think we should have people on board also, because I think I would want to make it as controversial as possible. So that's what the intention is. Anyway, so to begin with, I'll just start sharing my slides.
So Bhuvan, just 1 second. If you make it controversial, then summarize, please, because it's a purely academic, student-oriented session. We don't want controversies at the end once we conclude.
Okay.
So that is my request to you. All right.
So moving forward, so we had a 65-year-old gentleman who's a known case of hypertension and diabetes, which is fairly well controlled. And he is a resident of Delhi NCR, and he's a well-educated guy. And his primary caregivers are 2 children. And I think we all as an oncologist understand what is the meaning of having a good caregiver. I think that's where half of the cancer treatment or the supportive therapy comes in. There are no financial limitation for the patient, and he's also a beneficiary of a government health scheme. Now he has presented to us with a history of dysphagia for past 1 month in November 2019. So why I'm stressing about the time is because I think we as medical oncologists are very tuned to the recent advances which come in. A lot would have happened had the patient presented to us in November 2020 vis-a-vis the patient who was presented to us in November 2019. So he has a performance status of 0 to 1, and he has undergone obviously endoscopy, and which has been suggestive of a lower esophageal growth with lumen compromise. Now the biopsy has been done at an outside place, and it is suggestive of a squamous cell carcinoma. And the PET scan was done, which was suggestive of a growth at the lower esophagus and GE junction, with a single, a single liver lesion in segment 6. So the ancillary workup was done, and the organ function are normal. The viral markers are negative, and the echo is it's normal. So we have a basically healthy gentleman who has walked into our clinic with a dysphagia, with a lumen compromise, with a single liver lesion, with a a good performance status, and all organ functions are normal. So he was advised a biopsy for the liver lesion because it's a single site of metastasis, but the patient was unwilling for the same. And review of slides and blocks, which was done at the primary center, has suggested adenocarcinoma, and it is P63 negative. So a diagnosis of oligometastatic adenocarcinoma, esophageal adenocarcinoma, has been made. So moving forward, what I would like to ask my panelists, so Dr. Amish sir, do you think there is any acceptable definition of oligometastatic in esophageal cancer?
Not to the best of my knowledge. There is no definition. There are some suggestions, but I don't think there is any definition. If there is any definition, let me know. How I in my clinic look at it is, one, are they amenable to local treatment?
Fair enough.
And that's how you look at oligometastatic in any of the cancers, not only esophageal cancers, but any of the cancers. I think one of the most important thing in oligometastasis, Bhuvan, one thing which we always forget is performance status. Yes. In our zeal to define oligometastasis, if the patient's performance status is very poor and very symptomatically high because of the primary disease, even though you have oligometastasis, one here, one there, doesn't matter. The outcome remains poor.
Fine. So Dr. Nikhil, your idea as a surgeon, do you think there is something which you would define as oligometastatic, and you would want to take it to the table rather than pass it on to us?
As far as we understand, oligometastatic is a term coined by us. It's not something which is very standard, and a metastasis is a metastasis, right? So except colorectal cancer, I would mostly treat most metastasis as same, and we wouldn't operate.
So the idea which I get from you is that probably anything other than colorectal metastasis is supposed to be treated as a metastasis, is where you come in.
Absolutely.
So so let's ask the medical oncologist, Dr. Jitendra, what would be your take on it? Would you send the patient back to the surgeon for their opinion whether the patient needs to be resected?
So what I feel regarding in my limited experience, that we should first, in metastatic setting, whether it is oligo 1 or 2, 3 mets, we should first try out the therapy. We should read the biology, how it behave in vivo. So that is how we should deal. We should go ahead with the chemotherapy ahead. Then we should see the response, how it is responding. Then we should take our opinion from the surgeon, whatever he feels.
Fair enough. So, Dr. Vimal, what would be your counseling to the patient, whether you are doing a curative intent treatment or a palliative intent treatment? I think so. When's the first time the patient has come to the patient has good educated attendance, how would you want to counsel them, as a curative intent or a palliative intent in an oligometastatic setting?
So, to my knowledge, in esophageal cancer, the proper or I don't think of any trials where they have defined oligometastatic and treated them separately, and non-oligometastatic and treated them separately. In esophageal cancer, anything which is a stage 4 cancer is a very poor prognostic cancer. So I will definitely counsel them only as a palliative intent treatment.
So basically, I agree with you. So, but there are no set guidelines for esophageal cancer. However, I also take into point that each case has to be dealt individually rather than as a whole group. And so I take Dr. Jitendra's point of view that I would like to start with a systemic therapy and then see where it goes. Right. So fair enough. So Dr. Vimal, would your idea be different if the patient had presented, let's say a patient has a metachronous metastasis, not as a synchronous metastasis, but patient whom you have treated has earlier been treated and now present with a single site of metastasis. How would you approach the patient differently?
So that means he has already received treatment for his localized cancer. Now he is presented as a stage 4 cancer, but the metastases are limited. These are oligometastatic. So first, we do not know what is the oligometastatic in esophageal cancer. So considering if it is a single site metastasis, single or a single lesion, so at that time, I think I will at that time try to give a curative intent treatment, but not expect that much outcome. But I will try to give a curative intent treatment.
Amish sir, your idea to it, if somebody presents with you the metachronous single site metastasis in a esophageal cancer?
It depends, na Bhuvan. If patient has presented to you after 2 years of definitive treatment or within 6 months of definitive treatment, there is a difference between the two. I was just reading the chat box. I would want to tell everyone, yes, for academic purposes, for writing, answering in exam, you say this is a palliative case. But in a real day-to-day life, when you know that a metastatic C. esophagus is not going to survive beyond 1 to 2 years, anything and everything which is you can extend the life, I would not refuse the term oligometastasis in esophageal cancer just because we have paucity of data. Assuming a single liver met of 2 centimeter comes after 2 years, and PET scan nothing else, and initially it's a well-differentiated adenocarcinoma of esophagus, which is treated with chemotherapy followed by surgery. I would treat this still as a curative intent, but yes, telling the patient that this is a metastasis, and as Dr. Nikhil said, metastasis is a metastasis, but at the same time, my approach would be more aggressive compared to multiple mets all across the body. That is what I would do, Dr. Bhuvan.
So I think that's a very fair point. What you said is it entirely will depend upon the disease-free interval which the patient has had and how he has survived between the recurrence and the primary treatment. So fair enough. As we all understand, there are no established guidelines to follow in such cases. Yes, for an esophageal cancer which has metastasized, the prognosis is overall very poor. We all understand that. But then, each case has to be handled as a separate case, and the disease, the performance status, the disease burden of the disease has to be taken up. So just the last question, Dr. Nikhil, is there any particular site you would be a little more itchy about getting it operated rather than sending it to us? As in, or everything comes down to medical oncology if it's a metastatic esophagus?
So, I mean, as Dr. Amish has very rightly said, very selective patients in which a disease-free interval was fair enough, I mean, pretty long, then probably with explaining the patient, we might do something, but mostly there is no site criteria per se, where we would say, again, it also would depend on the magnitude of surgery. If it's a small liver resection, fine, we might go ahead. But if it's a very morbid major hepatectomy, I would have to think twice there. So it's about both things. What is the disease biology? What is the expected outcome? And what is the risk of the surgery? Putting all these three things together is a decision we'll take, and fitness of the patient.
Fair enough. So so just for the sake of students, even a synchronous oligometastatic esophageal, there is no doubt it is just plain metastatic esophageal cancer. For a metachronous, in a clinical practice, it will all depends upon the performance status, the disease-free interval of the patient. So moving forward, so this is this single arm FLOT 3 study which was there. This is a part of the the meta-analysis which was done which was published in World Journal of Gastroenterology, and they had taken up the patients who had limited arm B had limited metastatic patients, and the patients were analyzed for after the 4 cycles of FLOT chemotherapy. The patient had undergone surgery with service, no surgery. Obviously, the patient who didn't undergo surgery, they had unresectable or incurable disease. Some had dropped out. But just to highlight the point, the patients who did undergo surgery, the patient who had undergone surgery had a better overall survival as compared to the patient who did not undergo surgery. So what I'm trying to tell you is that yes, each patient has to be taken up as a separate entity and has to be treated therewith. So if you can look at the survival graphs with us, we all know that a single arm study will always come with a bias that the patient who had undergone surgery obviously had a responding disease, performance status were better. But then even after those caveats, a surgery does add somewhere to overall survival is what I wanted to tell out of it. So started on, so obviously the patient, it was for the sake of discussion, we have moved on, but in a real life practice, patient had presented to us with a synchronous metastasis. Patient was started on a cytotoxic therapy. And so coming back to I think the topic which has been, comprehensively covered by Dr. Vora. Jitendra, what do you think? The patient you would like to start the patient on a single drug, 2 drug, triple drug, immunocombo? What you want to think of?
If sir he or she is not able for any targeted immunotherapy, definitely double drug is preferred. If PS is very, very good and you want to do anything extra, then you can go to triple drug.
So basically, see, you'll have to add it. You will have to evaluate the patient for immunocombo, right? So what I'm trying to, so basically, just let's answer this. What are the
right now? Yeah, right now, yes, I am doing IHC for MSI and RT.
Okay, and Dr. Vimal, anything else would you want to include in the patients?
MSI, PDL1 and HER2 new.
PDL1 by?
PDL1 by IHC.
TPS, CPS?
CPS, because the studies have been based on CPS.
I think this is what probably Dr. Shefali was trying to, Dr. Amish, would you like to add anything else to these additional tests, or these are the additional tests you would like to order in a patient who has presented to your clinic with metastatic esophagus?
These are fair enough.
So
one question, sir, how many of us are doing NTREC? Because NCCN does mention that NTREC has to be done. So that's how many of us are doing?
So that's for the second line. Once we move to the first line and beyond, I would probably bring in the NGS then.
NGS.
Then for the first line, when the patient has come to me in the clinic, I probably would want to, limit myself to these four is what I can think of. So now, Dr. Vimal, let's say the patient. So your idea would be if the patient would be still. So you agree with Dr. Jitendra that it will be 2 drug, and if the performance is very good, you may choose for 3 drug, or you will never choose a 3 drug.
If these markers are negative, then I will choose 2 drugs, because as Dr. Amish has rightly said, 3 drugs doesn't have much benefit compared to the 2 drugs. So I will choose 2 drugs.
So I mean,
also Bhuvan, in the era of Ramuciroma, in case if you're planning to use it, and the Rainbow trial had shown that addition of taxane. In fact, the taxane addition is used in many of the immunotherapy drugs as a control arm also. So I feel taxane in the second line also serves a very good purpose along with irinotecan. So if you use 2 drug regimen, especially in adenocarcinoma, and you have not used taxane, you can think of ramucirumab with paclitaxel, and that would give a first and second line combination of 2. DOX or DCF is the only 3 drug regimen which have shown to improve the survival as compared to 2 drug regimen, that also in a phase 2 trial, not in phase 3 trial. So for all practical purposes, I think doublet, as Dr. Vimal said, would make more sense, even in a fitter patient also. I feel that.
So let me just put it in a very clear term. There is no patient per se you would choose a triple drug. You would rather save a taxane to be added with the VEGF ramucirumab rather than adding it upfront. Is that what the understanding?
Bhuvan sir, I will just help you in creating a controversy. So this is one patient which we had treated when I was doing my DM. Patient was a young male, 40-year IT employee. He has only one supraclavicular lymph. Nothing else was there. We have given him EOX. So patient had a CR. So means this is how we can use a triple day combination.
So fair enough.
And
so
later on,
is there any subset? So let me to all the.
That's why I told if you want to do something extra, then you can go like.
Even Dr. Shefali, is there any patient you would want to use a triple drug?
Dr. Jitendra.
Sorry, Bhuvan, come again, please.
Is there any patient you would want to use a triple drug? We all know the sequence we would want to put the drugs in, right? So the rationale given by Dr. Vora is that he would rather save the taxane for a second line rainbow kind of thing rather than upfront. So is there any patient who would use a triple drug?
So I completely agree with Dr. Vora. Like he very elaborately showed that NCCN guidelines also that there is no advantage of triplet over a doublet in such a setting. So of course we need to have some kind of drug saved for the later lines if there is no targeted or actionable mutation available. So I would prefer a 2 drug. So in absolutely fit, no cardiac issues, I will discuss the option if the patient is keen on that thing. But otherwise, my preference is also the double drug regimen.
So let me play the devil's advocate. Why do you want to save something for the second line and not do it in the first line?
So since we have seen the 2-drug versus triple drug, there is no add-on advantage. So that is why. So why to give additional toxicity and rather not to save the next drug for other line?
So the message which needs to go out of it is there is no additional benefit of giving a triple drug in a metastatic esophagus. You are consuming your drugs, you like it or not, how much ever you want to argue it out, you will require a second line of therapy. And when there is no additional benefit, it's only going to add toxicity to it. You might as well give a double drug, then a triple drug combination. Anyway, moving forward, the patient had a HERCEP negative, MSI was stable, and the PD-L1 was CPS by 5%. Now, in today's era, you may have chosen to treat it differently, but then, the patient had presented to us in 2019 when the data for first-line nivolumab was not available. So the patient was started on a triple drug, MDCF kind of therapy for every 2 weeks. So, with evidence now available, would you have done anything different, Dr. Amish? Would you have chosen to include immunotherapy into the first line, or you would have still gone for a
option you have to give, na Bhuvan? Today's age and world,
would you give it
CPS is 5%. CPS is MSI stable, adenocarcinoma, first line CA esophagus. I don't think I would like patient to choose immuno plus chemo right now. But at the same time, if patient agrees to use and we have CPS more than 5% and we have nivolumab approval in that, I would offer immunotherapy plus chemotherapy to this patient. But if given to me to decide, I would choose chemotherapy first line, followed by immunotherapy in the second line.
Dr. Vimal, your take on it?
So, as you have introduced the patient, he has a good PS. There is no problem of finances. And with a CPS score of 5%, I think the advantage of adding first-line immunotherapy is there, according to the limited data, whatever we have. The checkmate, I think 640 something study was there. So I would like to give a nivolumab plus a modified FOLFOX or a capox regime.
So you would choose a immunochemo combination.
Yes.
How would you? So sitting in max, would you not give and let others give immunocombo is what I'm asking.
So Dr. Bhuvan, he is not in max right now.
No, I'm just saying. So, so
he has that liberty now.
So answer the question at least. Would you give immunocombo or just a immunocombo? Fair enough. So Dr. Jitendra, do you think there is any other difference between squamous and adeno other than the anti-HER2 therapy when it comes to the first-line therapy in squamous and adeno esophagus?
Definitely, there is a lot of difference what Sir has also alluded into. Regarding the treatment aspect, one more thing is also there that anthracycline doesn't work with squamous, and HER2 is only positive in adeno.
So I think I wanted you to bring out the point. The anthracyclines are, they're known to work better with the, GI junction and stomach. Fair enough. Moving forward, Dr. Amish has already discussed this data which is available to us. The nivolumab data with the checkmate data which is there, in which the nivolumab was added along with the doublet therapy, and there was a third arm which had nivolumab and ipilimumab in it. And what is needed to be seen is patient had obviously it was adenocarcinoma. In the nivolumab arm it was adenocarcinoma, and what was seen was the overall survival differences almost. One second. So the overall survival is differences around 3.5 months, and moving forward. Then there is the there is data with the CPS score which is there. So one second. So the safety profile is there. So to conclude, in a 649, the patient had a median overall survival advantage of around 3.5 months, and that was a significant benefit, and that's what led for the the investigators to believe that the Nivo-CT combination may be the new standard of care for advanced gastroesophageal cancers.
Yeah, Bhuvan, sorry to interrupt in between. So Dr. Dodul and Dr. Chhavi are also there. I know.
I'm just
no. So just my. I understand, but my point was, let's have their outlook also. If they agree to in a palliative setting for that much of thing, or do they have a different point of view altogether, apart for discussing the trial's nitty-gritty? Yeah.
Okay, fine. So let's move forward. Moving forward, let's take it there. So just to conclude the two, basically, both of these data have brought in immuno-chemo combination to the picture. Anyway, we moved ahead, we treated the patient. The 5th cycle of chemotherapy was given, and the patient had complaints of dysphagia and feeling as if the food was getting stuck. Now, the patient underwent a endoscopy, which said that the growth compromising the lumen, and he underwent stenting in the same go. Now, moving forward, because the patient had a feeling of having the food stuck up in the throat, there was always, and this obviously the growth that clinically it meant that the growth was increasing in size rather than decreasing in size. A PET scan was done, but it was found that all the disease, including the gastroesophageal junction disease, was responding. Now, moving forward, so I would still like to include Dr. Nikhil's opinion here, just for the last time, I guess, with a patient who has a responding disease on PET scan after the 4 cycles of chemotherapy. Would you still rule out a surgery, or would you want to consider in a surgery, especially when the patient has presented with the obstructive symptoms?
No surgery at this point of time.
Fair enough. So
he has to have a very good disease-free interval before we even can think of surgery.
Fair enough. So further courses, patient even after having undergone a stenting, still complained of obstructive symptoms, and endoscopy was repeated. It was suggestive of a stent blockage, and the stent was taken out. Now, I would like to include my radiation oncology colleagues, Dr. Chhavi and Dr. Dodul is there. So, Dr. Chhavi and Dr. Dodul, please tell me, in a patient who has presented to us with a esophagus cancer in the lower GE junction, where there is a chance of stent migration, where there is a chance that the stent may not adequately work, because stents are supposed to adequately work in a middle esophagus rather than more in a lower esophagus. Now, in a patient such as this, what do you think is the cause of a persistent dysphagia, despite the patient having had a responding disease, having had undergone a stent? Do you think there is anything which you would like to, which as a radiation oncologist you feel this could have been a better managed by a palliative RT rather than a stenting? So, Dr. Dodul, I would like your opinion on that, please.
Yeah, I think we should consider the role of radiation in palliative setting, and complications related to stent are not unknown, particularly stent migration, inflammation, infection, perforation. They are quite common after stenting in esophageal tumors. And sometimes we forget about the role of palliative radiation, which is a very easy to do thing, lesser complications, and patient really get good symptomatic relief in terms of feeding, swallowing, providing relief to pain and dysphagia. And the effect is also persistent. Other problem, what happens with stent, sometimes are overgrowing of the tumor at the end of the stent, and they can block the stent. So that does not happen with radiation. Essentially, when we deal with a metastatic disease, our expectation of life is not very high. And an effective radiation, good quality radiation, can provide adequate relief of symptoms for that period.
Fair enough. So just moving forward, I'll take your. So patient was planned for a palliative radiation with the intent of relieving dysphagia. Now, obviously the discussion happened whether the patient wanted an upfront Ryle's tube placement vis-a-vis getting a Ryle's tube done if there was a complete grade for dysphagia, and it was planned for a short course RT with the short course radiation with the Ryle's tube in place, underwent 30 gray in 10 fractions. Now, what I wanted to ask with you, Dr. Dodul, was, do you agree with the treatment course? Would you have done it any differently in a patient who has presented to us with the obstructive symptoms?
Yes, I agree with this. 30 gray in 10 fractions is quite a standard of care for palliative setting. And the question of whether or when to put a Ryle's tube, that's a very much subjective decision. What I feel, I go through the scans, look at the nature of the disease, the amount of lumen which is open, and whether initial few days of radiation can cause edema and block that. If that is the scenario, then I always prefer putting a Ryle's tube before starting radiation. If the lumen is quite adequate and if patient is eating normally semi-solid or solid food, then I really do not feel that putting a Ryle's tube would be necessary, and most of the time patients do not require it. If at all, that's a scenario that even when patient was able to eat or eat solid or semi-solid and have absolute obstruction after starting radiation, then a guided placement of Ryle's tube or some FJ tube can be considered.
Dr. Chhavi, I would like to
very honestly, I am not very keen of doing ILRT kind of palliative things in esophagus, because most of the time later on they produce a lot of scarring and obstruction because of inhomogeneous dose distribution due to ILRT. So I'm not in favor of that.
So, Dr. Chhavi, I would like your input. Suppose there is a patient who was presented to us with mild dysphagia, such as this. How do you decide whether the patient, I understand that you are a radiation oncologist, you might have an inherent bias towards radiation, but let's take it the option of stent, vis-a-vis Ryle's tube, vis-a-vis radiation. I think these are the three options which are available to us as clinicians when the patient presents to us with the dysphagia. So how do you choose, Dr. Chhavi, between these or three? This is where I would need to do this. This is where I need to do this. Is there something of an algorithm in your head?
Yes, actually, am I audible?
Yes.
Yeah. So actually, the algorithm we generally practice in our clinical scenarios is, first of all, what is the PS of the patient and what is his longevity. Like we already know that this patient is a metastatic patient, which is oligometastatic. The PS is good. We are considering him for a doublet or maybe a still higher inputs into chemotherapy. And so I expect to achieve a longer period of dysphagia relief, as Dr. Dodul was mentioning. So I would prefer radiation over stenting in a patient like this for relief of dysphagia. Because stent has its own issues. It's a lower esophagus. Stent migration is a high risk for the patient. B, the patient post-stenting have, what I have seen in my clinical practice, a lot of post-stent pain complaints. Patients are very uncomfortable at times. Then again, there is a regrowth of the tumor, and there might the patient again might have dysphagia because of the tumor overgrowth into the stent. So, and if you give stent first and then give radiation, the risk, the percentage of patients having mucositis is very high. That is esophagitis. So I would prefer starting with radiation first in a patient, especially who is able to at least have some adequate, maybe liquid diet, or maybe place a Ryle's tube first and give radiation, so that he has a longevity of this dysphagia relief. And I believe so that's how we should go ahead for.
Dr. Dodul, suppose there is a patient who has a middle esophagus, not a lower esophagus. What I would want to ask with you as a medical oncologist is, I ask your opinion, does he require a palliative RT to esophagus for dysphagia control? What would be, so we understand, so we're talking about a middle esophagus where the stent would have worked equally good as probably almost as equally good as a radiation. When would you say that he requires a radiation? When would you turn away that he doesn't require a radiation? I think you can make do without radiation. And what would you say, okay, let's put a stent and not do radiation?
So you are asking me?
Yes, yes.
Okay, I heard a medical oncologist. The question is, it always, like, if there is a need for radiation, I really do not prefer putting a stent. The risk of stent migration is always very high after radiation.
For radiation is what I'm trying to understand. So for the clarity of all of us, for the clarity of the listeners, what is the need for radiation is where, where is the cutoff where you will say radiation is required?
So in a palliative setting, it's only to provide relief from the obstruction and dysphagia. If the patient is doing well with chemotherapy, not having any dysphagia, eating well, I really am not very keen to go for radiation. The purpose is very clear to me that I am going to provide symptomatic relief. So what kind of symptomatic relief I can palliate with radiation in a metastatic patient is providing relief from the mass effect, that is in terms of obstruction. So eating problem, swallowing problem, that's it.
So fair enough. So the message we need to go out is I think we as medical oncologists and we all as clinicians, we need to get over this, bias against radiation, and I think choose a palliative radiation for dysphagia rather than choosing the stent. We may choose that the stent is easier work to do, but then the stent-related complications is what I get out of this discussion is.
Yeah, one more point what I want to add on, like putting a stent is not treating the tumor. So radiation serves both purposes. It provides symptomatic relief, and at the same time, it has some anti-tumor effect. That definitely helps in regressing the tumor. So stent is just for a very small duration relief. It's a temporary relief.
Fine. So choosing a radiation to treat a obstructive dysphagia is a better modality than putting the stent is what I get out of the discussion. So Dr. Shefali, Dr. Nikhil, do you agree with that?
I forgot to answer another question when you asked me when not to plan for radiation. Yes. So there will be occasions when you will find the tumor is perhaps infiltrating the tracheal fat plane or going within the trachea. So that will be one condition where I will not consider radiation. And I'll rather send the patient for double stenting, putting a stent first in the trachea or bronchus, and then putting the stent inside esophagus. That will be my approach, and no radiation at all.
Good, thank you. So moving forward in the evidence, I think we are all running late, I guess. So let me just move a little faster. In view of no evidence of disease progression, patient continued on modified DCF. And at the end of 8 cycles of therapy, the patient had an interval decrease in the GE junction growth, and that possibly was because of the local radiation which has been given, and he had interval increase in the size of segment 6 of liver. So further treatment, Dr. Jitendra, what do you think? The patient who has had responded well to the therapy initially now has had a disease progression in the site of at the site of liver. What would you do next?
I don't think he's a good candidate for local therapy. The reason being, if the disease is resistant, it will be resistant in the other places also. So probably the best way is to change the therapy. And the evidence, what I say, either it's a Ramuciroma or a poor patient Ramuciroma, that is irinotecan, which is 2 options available. But if the patient is really, really affordable, then I will try to put a NGS in. Then I will see where it goes.
Vora, sir, you still there?
Yes, I'm there.
Sorry, sir. What would you do, sir, if the patient has had a progression at the liver site?
You said initially patient is looked after well by 2 sons and financially very well off, right? Hello?
Yes, sir. You're right. Yes, sir.
So the point is that primary site is controlled. We have in this patient, apart from modified DCSF, we have not given anything else. We have not radiated local site also. So primary site is under control with chemotherapy, while metastatic site is progressed. So, and the metastatic site, you get the maximum information if you do NGS at this point of time. If patient can afford, I would do, because since the second line, you have already used taxane in the first line. So second line taxane is gone. One. Second thing is this patient CPS is 5. So you have only option of one immunotherapy drug and not the another immunotherapy drug. That also, sort of a borderline benefit. So this particular point of time, I think we would require NGS for further information. Maybe at this point of time, NTRK and you use larotrectinib, entrectinib. I'm just thinking aloud. One such patient like that, Bhuvan, you would be surprised that NGS through MLH1 gene abnormality. And we treated this patient with immunotherapy. Patient did extremely well. So this is what I would do.
So moving forward,
Sorry?
So patient obviously was transferred for a systemic therapy, and but I don't know, the sons being the good caregivers, they were very keen for the local regional therapy. There was a lot of discussion which happened. The second system will.
Bhuvan, I think there are network issues at your end.
Systemic therapy was obviously discussed as the first thing. They just
Yeah. It is better. Yeah.
So I think there was a lot of discussion in terms of systemic therapy and a local regional therapy. The patient, obviously the son, they were very keen on local regional therapy, and they believed that the local therapy had worked for the esophagus, so they might as well work for the liver also. They went against the clinical judgment, and obviously they went to the radiation oncologist, GI oncologist, who said nothing doing. There is no surgery which is to be done right now, and I think Dr. Nikhil would agree to us. However, they went to radiation oncologist. So, Dr. Dodul, if they had come to you with this proposition, what would you have done?
I would not be very keen in treating with radical intent, because the disease biology is not that much suitable. I think Dr. Nikhil might be laughing at me because he might remember we fought so many times, and I was so keen to treat some patients with radical intent in so-called oligometastatic setting, because the patient had single brain mets. And I think that patient did fairly well. But again, at the end, biology remains the king, and this patient does not fall in a very good biology tumor setting. So maybe only a palliative intent treatment with any form of systemic therapy, or any attempt would be a kind of wild attempt without any significant meaningful benefit.
So I think people at the treating center didn't have the conscience as you have. So they underwent, the patient underwent IGRT 5 fractions for the liver lesions, and phase 2 GE junction radiation for 10 fractions. So Dr. Chhavi, do you agree with this, or you also tend to side with the... Chhavi, you there?
Dr. Chhavi,
Dr. Chhavi, unmute.
Sir, what I would like to add, yes, there's definitely a conscience part, as Dr. Dudal said. But this patient has responded well to the first line therapy, and thereafter has a progression at a metastatic site. And though I would say that my intent should be palliative, but liver SBRT could be done in a palliative setting, because that is the only site which is primarily progressing and active. So yeah, I agree with SBRT of liver as a palliative setting.
May I ask the question one? Like, it's a palliative setting, and what benefit are you going to get by doing SBRT to liver lesion? Although the initial response to chemotherapy was okay, but the duration is hardly 6 months or so.
Yes.
And that's perhaps the basic minimum time which we want to buy, that at least more than 6 months or so, the disease has to remain under control. Sir, please.
Sir, I always feel is that since it's a palliative setting, the disease which is actively seen, if tackled, the patient's DFS is increased. So, and I don't know whether you will agree to this or not, and even medical oncology colleagues will agree or not.
Amish wanted to pitch in something. Sir, please.
Yeah, so Dr. Chhavi, because I can say this because now I'm outside Max.
Sir, I'm hardly very short-term part of Max. I've been working at R&R hospital till now.
We go by data. What you are saying is a gut feeling and probably an emotional thing to help patient. You are talking about that. Please remember, on chemotherapy, patient has progressed. The primary is under control right now, and the secondary is progressing. So on chemotherapy, progression of the disease, chemotherapy and radiotherapy both working simultaneously side by side. We all know that if one works, the other will work. Adding SBRT at this point of time to one lesion when there is a circulating tumor cells in the body, and then you are basically taking it other way. In absence of any data, Dr. Chhavi, I think this is not the right decision in terms of the patient management. That is one thing. Second thing is, you'll have to think beyond chemotherapy in this patient, or in that matter, chemo and radiotherapy both in this patient. because on treatment, patient's liver is escaped. So you'll have to think of either anti-VEGF, or you'll have to think of immunotherapy, you'll have to think of these aspects to change the gear and try the patient to make live longer. But here the case is very simple, because Dr. Bhuvan said that patient's family decided for radiotherapy. So our life is much simpler here. But there is no scientific evidence to treat SBRT and local esophagus by radiation to the best of my ability and knowledge, Dr. Chugh.
I think, so what I'll do is, I agree with, I'll move forward with this, but I do agree with Dr. Amish, and I think this point only comes when you reach the level of seniority. And I do understand this because, as a mother, I probably had the same feeling when I began. I think if you had a discussion with Dr. Nikhil in your coffee rooms, you would probably understand as you move, go ahead. And if you sit with Dr. Amish and Dr. Nikhil, you'll probably understand that, the patient disease is advancing, and you try to, if you try to still be curative about it, you probably understand that it doesn't help is what the message out there is. Anyway, moving forward.
I want to ask one question. So I just put it in the chat box also. So is there any benefit or say kind of abscopal effect, which we discussed? Okay, if the patient has received radiation and then give immunotherapy, does it benefit or it is futile? Only the second line immunotherapy is equivalent. So how do we take it? So you can answer or your panelists can answer. I'm okay with all of.
I think
Dr. Shefali, I can take the question.
Yeah, Dr. Dodul, please. Yeah,
there is
please.
no data to support the role of SBRT on the first line. So that answers your question.
But what he's saying is
no, it's not the first line. On progression, this very scenario.
So no, what I am telling, there is no data to support benefit of SBRT, and there is, as of now, there is no trial to support SBRT followed by immunotherapy in metastatic liver cancer. So going by data, as of now, no. Now,
so I think,
but Dr. Shefali, you pose a very good point, and I agree with Dr. Dodul that there is no data in esophageal cancer. But please remember, ex-US President Jimmy Carter had brain metastasis and metastatic melanoma. His brain RT was actually given for benefit of immunotherapy in future, and 6 years down the line he is still in CR, as you could see in the Independence Day parade this year 2020. He was waving the flag. So Dr. Dodul, theoretically sounds like a very good concept, huh? It is not a bad concept, but you are right, there is no data in esophageal cancer. Theoretically sounds a very good concept.
So Dr. Chhavi has a point.
I fully agree with this. The only thing what I wanted to say that this should not guide us for as a routine practice. I worked with Dr. Nikhil almost couple of months to treat a patient with curative intent, go ahead with surgery and everything. But that's definitely not something which we do on a regular basis. So the patient had good
systemic
therapy, remained disease-free after treatment for 6 months. And I clearly remember only then he considered the patient for surgical resection. So
that's Dr. Nikhil. He's the wisest of us all, is what I would say.
Nikhil, your comments, please.
I think he didn't get anyone since morning.
Yeah.
So what I would say is, okay, Dr. Jitendra, what next?
What next? We will do an NGS and then we will get the report.
Oh, yeah, I'm sure. I don't want to say it in open forum. So NGS ke piche pad gaye. Anyway, it doesn't matter.
This is what I've been taught by series.
Dr. Vimal, what would be your next story?
So it will depend upon, because what he has received in the first line and what his present PS is.
What do you want to choose out of all these?
So I will choose, if his PS is good, a fall-free plus Ramuciroma or an irinotecan plus Ramuciroma.
Why not a drug holiday? Both the diseases are covered. Both the diseases which were there have already been irradiated. There's no visible disease as such. Why not give a drug holiday to the patient?
But the point is, a drug holiday is eligible for a patient who is responding. Now he has already started progressing. So in that scenario, probably giving up drug holiday is not a good.
Okay. So let's move a step ahead. Why not give a maintenance capecitabine?
DCF
response, Bhuvan, what was the response to radiotherapy at both the sites? Has there been imaged?
So yes, the disease was responding. There was a CT scan which was done, and I've missed the CT scan just for the sake of the fact. Obviously taken it out, but it was a responsive. Both the sides were responsive. There was a post-radiation change at the liver side, and the esophagus has not progressed.
Okay, very good. Good point. Before radiation, the second question, Bhuvan, applies if you would have done the rebiopsy before radiation. Na? After radiation, yes. It is very difficult to say. Although we all would love to have the PD-L1 expression, because CPS is a very, very funny thing. I could not cover in my lecture, but tumor cells plus inflammatory cells after chemotherapy, after radiotherapy, how much of inflammatory cells are there, and that would define your CPS is a very difficult thing to say. But yes, escaping liver lesion, CPS score would make a difference. If both are responding, I think probably the capecitabine alone will not make a difference because you are already giving 5-FU, and on 5-FU, the liver lesion has increased. So probably the capecitabine maintenance may not be a right option in this patient as terms the systemic or the metastatic disease. Give a drug holiday of 1 to 2 months, and after 2 months repeat the scan is not a bad option if you discuss with patient. At the same time, you go for second line treatment also is not a bad option.
So my idea behind this was, see, the patient has had the disease. There's no new disease which has happened. The patient has had disease control everywhere else other than the lesion to begin with, which was the liver lesion. I understand there may be some clones which were not responding to the therapy. And that was, anyway, so I think I'll move forward from there. The patient was started on Capox-based regimen. From August to October, he took 3 to 4 cycles. He obviously had a poor, tolerance to the therapy. And in a retrospect, it did not seem like a good idea. And the patient has a progressive dysphagia. And in the end of October, he had a disease progression. However, and there was a new capsular lesion in the segment 5, there was a new capsular lesion. And the patient still had a good performance status 1 to 2. Now when there's a new lesion, what would you do? So all the 3 medical oncologists and Dr. Shefali included, all the 4 medical oncologists, what next? Do you change to Ramuciroma irinotecan? You change it to immunotherapy, or you do an NGS and look for agnostic approach or NTRK. So Dr. Vimal, would you like to take that question to begin with, and then we'll
yeah, sure. So first, I don't agree with using Capox after DCF.
Okay, let's move forward. The Capox is done. We have
now definitely if they agree, I will go for an NGS first, and then decide about the future course of action.
So why not Ramuciroma irinotecan? It's still a second line. So we have.
It is a second line. If he is fit enough, we can go for Ramuciroma irinotecan. Because it's an adenocarcinoma, we should. It's a very good choice to go for Ramuciroma irinotecan.
Dr. Jitendra, what would be your?
Probably, if NGS is not working, I will go ahead initially only with Ramuciroma, because marrow is not that much good that it can bear the 2 drugs actually. Because irinotecan, it will be really hard to tolerate. So probably we will have to go with Ramuciroma.
Dr. Shefali, would you like to pitch in?
Yeah.
Then take the closing statement.
Yeah. So of course, if NGS patient is willing to do so, of course, is the preference. Otherwise, Ramucirumab, taxanes you have already given. So Ramucirumab along with irinotecan, if the marrow, like Dr. Jitendra said, would permit. So I would like to go for that combination.
Amit sir, your take on it?
So if you have to blindly follow, or if you have to strictly follow NCCN guidelines, CPS is more than 1. 2 lines of chemotherapy has been received, DCF and Capox. So pembrolizumab as a 3rd line treatment in this patient. Okay,
Agreed.
That is 1. So you won't be wrong, and there is a data also to suggest about that.
Okay.
If patient is not able to afford, say, pembrolizumab, assume karo for the theoretical discussion, I would take a biopsy from GE Junction. I would retest the biopsy for NGS also, PD-L1 also, because GE Junction have now started growing up after the initial diagnosis. So I would take the biopsy from there, do a rebiopsy, do PD-L1, do NGS. Meantime, either start Ramucirumab or irinotecan. Irinotecan less likely for 2 reasons. Patient has progressed on DCF and Capox. So by definition, it's a chemo-refractory disease. So adding irinotecan will add on to the toxicity and nothing much. Ramucirumab, anti-VEGF in a way, and wait for NGS. That is what I would do, Dr. Bhuvan.
Fine. So
Dr. Amish, one question. So do we really label him as a chemo-refractory? He has already surpassed that time, November 2019 till now, again Feb 2021, or say December 2020.
Yes.
November 2000. No, go one slide previous. Still in less than a year, Dr. Shefali,
Yes, sir.
2 lines of chemotherapy, SBRT to liver and RT to esophagus, all has been given.
No, but we need to understand we are considering it as a 2-line of therapy. It's essentially the same drugs. It's a platinum.
Yeah, actually.
I agree with you, Bhuvan. There is you can look at it that way also. What I see is that both the times patient has progressed on chemotherapy. Whether you consider the same or whether you consider the different, but as I said, it can be looked at the way you said also, Bhuvan.
So the patient he underwent Irinotecan and Ramuciroma and did exceptionally well for 6 cycles. He had a good go at it, and there was no significant myelosuppression, and the patient tolerated it well. In the end of February, at the mid of February 2021, the reassessment was done, and there was interval increase in the size of segment 5 lesion only, and there was nothing else which was there. And so now the patient underwent an ablation of the liver lesion in March 2021 because that was the only site of progression. Now, so I would like to, to come into the point that he may not have tolerated irinotecan, but he took 185 milligram of meter square irinotecan every 2 weeks for 6 cycles. He did well. And anyway, moving forward, what next now? Once the liver lesion has been ablated, would you want to continue with irinotecan ramucirumab because he has been doing well, or you want to change to immunotherapy, or you want to treat drug holiday and treated progression?
I would take that. Third option is correct option, not a bad option. One, because patient has been treated extensively, drug holiday of 2-3 months is not a bad thing. But my preference would be the first option, Bhuvan, because patient has done well on irinotecan and ramucirumab. I would like to continue that till the time there is any progression or till the time patient can tolerate the combo.
Fine.
No change to immunotherapy because there is no progression here.
Dr. Vimal, what will be your take on it?
Yeah, I fully agree with Dr. Amish. If he's tolerating and there is no toxicity, so irinotecan ramucirumab we should continue.
Dr. Jitendra, your take?
We will continue with the same, sir.
Dr. Shefali, would you want to be using immunotherapy now or no?
No, wait till he's doing well for 1.5 years now.
Dr. Shefali, your smile is very mischievous, huh?
No, sir, it's absolutely clear. Nothing mysterious.
Moving forward, the patient, to be clear, the patient is no more under treatment. I changed hospital and he's been getting treatment somewhere else now. So he started on nivolumab in April 2021. He is due for his third second weekly nivolumab tomorrow or day after tomorrow is what I understand. And
you have a good follow-up, Bhuvan. I must appreciate that.
He has had, ma'am, I called him up. This is all Medanta's good record keeping, ma'am. I must compliment Medanta record keeping. Anyway, so he has lost, however, and he's planned for reassessment after 6 doses. And rather, I sent him a message that, with the moment the new disease comes, please get an NGS done. I think this is the high time you should have gotten NGS done by now. So this is how it is, and I'll thank all of the panelists for.
A very good case, huh, Bhuvan? Very good case. I must compliment that.
Very good.
It has covered all the aspects. Very good case.
Yes,
Yeah.
wonderfully.
I agree.
Wonderfully.
And you have crossed
So,
18
Dr.
months
Nikhil?
also.
Yeah. So yeah, and thank you so much, all of you. It was a wonderful discussion, another fruitful session for all of us. Dr. Nikhil, I think we should wind up.
Definitely. It never, the stipulated time is almost 1 hour and we always exceed by almost double.
Yeah.
So
I think we need to change the format now. 7 p.m. onwards, we should write.
I'm so sorry I exceeded my time today. My sincere apologies for that.
No,
so
sir,
Dr.
no.
Shefali, if you see, I don't write 7 to 8 p.m. It's just 7 p.m.
7 p.m.
Yeah.
There's no ending
We are
time
wiser.
there if you would have
We
noticed.
all are wiser by now.
Again, ambiguity comes with seniority. I understand.
So anyway, Bhuvan, actually that was wonderful. When you told me that you are just presenting one case and I said I am skeptical that all the points will be covered, but then you managed to cover almost everything. Everything, and that's very helpful for the students. So I'm very thankful to you for that. And with this, I would like to conclude. It's 47, and I'm sure you must be getting stares at your home. So thank you very much. Thank you, everyone. Thank you, participants, and thank you, esteemed panel members. And next topic, we are going to cover GE junction. GE junction is always very challenging because even the surgery or neoadjuvant radiation versus chemo, even the types of surgery, whether we do a stomach pull-up or we do a esophagectomy, we do a intrathoracic anastomosis or a total gastrectomy, everything is very, very fluid there. So it's going to be an interesting discussion. So with this, good night, everyone. Thank you very much.
Okay, thank you so
Thank
much.
you so
Thank
much.
you so much. Thank you.